Thank you for the kind introduction, and thank you to the Heidelberg Global Diabetes Research Center for having me in the guest lecture. So in the next 40 minutes or so, I'll present a little bit on my previous research that I did during my PhD on HIV epidemiology, and then next to that I'll present some of the work on HIV integration and healthcare delivery innovations. So the presentation is called Pathways to Progress, Advancing HIV Healthcare Delivery Models in Low and Middle Income Countries. Probably with questions, it's easy to keep them to the end so that the people joining online can also ask questions. A little bit about me. So Rodrigo actually talked about most of it already. I did my studies veterinary medicine in Utrecht in the Netherlands, after which I did a master in epidemiology, and I joined the Department of Public Health at the Erasmus Medical Center in Rotterdam in the Netherlands for my PhD in global health. I defended my PhD last April, and last year I joined as a research fellow at the Health Systems Innovation Lab in Boston. So my scope of work, my research so far focused mostly on HIV prevention and control, mainly in Eastern and Southern Africa. This was also what my PhD was about, and next to that I did several studies on the epidemiology of neglected tropical diseases, mainly visceral leishmaniasis and leprosy, also a bit of soil-transmitted helminths. And next to that I'm working on health systems integration and innovation. So I thought, just as a refresher, I start with a brief history of the HIV pandemic. So HIV came up around the 1980s with many cases in the big cities of the US, but also already soon we discovered that cases were spread out among many of the global world regions. The first antiretroviral therapy, so treatment for HIV, became available in 1996. And next to the benefits of treatment of enabling people living with HIV to have the same life expectancy as people without, it also has the benefit of reducing the chance of transmitting the virus. So due to these successes, there was around the 2000s the big global initiative of scaling up ART worldwide. This was led, among others, by former President George Bush and Kofi Annan through PEPFAR and the Global Fund. And these efforts resulted in scale up of ART in many countries, largely through vertical HIV systems, so really clinics that solely offer testing and treatment for HIV. And due to these successes, in 2016, during the UN Health Assembly, first the big global goals of HIV were discussed, which is ending the AIDS pandemic by 2030, which is still largely up for discussion. So where do we stand now? HIV-related deaths are declining globally. And then when you look at the map here, HIV prevalence is highest in Eastern and Southern Africa, which you see in dark red on the map. So I'll quickly go through this. So basically there are two important targets for this presentation. One is the HIV target related to the cascades of care, which is that it's called the 95-95-95, which means that by 2025, the ideal target is that 95 people living with HIV know their status, and of those 95 are on treatment, and then of those 95 are on successful treatment. And next to this, there is the broader target of universal health coverage, requiring population-wide access to healthcare more broadly. So what are the biggest challenges for HIV? I want to name three, which is firstly the big geographical variation in HIV burden worldwide, but also within countries and within populations. Then secondly, the HIV pandemic knows so-called high-risk groups. So these are, for example, men who have sex with men and sex workers. These populations often have significantly higher risk, but are also harder to find to provide prevention and treatment services. And then thirdly, despite the fact that the number of people living with HIV is still rising, funding is decreasing. And then the fourth big challenge relates to the changing disease burden. So as everyone here probably knows, there's a shift from infectious diseases to non-communicable diseases. in many of the low and middle income countries, among which many of the sub-Saharan African countries. And people living with HIV are at disproportionately high risk of developing diabetes and hypertension in many countries, showing the need of looking at different disease models. So this is what I will focus on during this presentation to some extent. First one of the studies I wanted to highlight is really related to HIV, and then I will also move over to diabetes and hypertension. But I think this study is important since it highlights the big variation in HIV burden. So in this study, we looked at two things. First, we looked at what is the geographic variation in HIV prevalence among adults and among young adults. And then we looked at which factors can explain this variation. So I will take you through this. For the study, we used the demographic and health surveys data, which are nationally representative data for many different countries. But for the study, we looked at 7 countries in East and Southern Africa, which you see here in green on the map. And we use different, like next to this data set, we use different environmental indicators to look at risk. So this is the DHS data. I think definitely worth having a look for everyone because it's really useful data for HIV, but also they have diabetes and hypertension information. Here I'll quickly go through. So what we basically did is we pulled the data for these 7 countries, and here the dots that you see on the map represent the data points. The data is georeferenced, so for each cluster, like each sample location, we know the GPS coordinates of where these people reside. And what we basically did is, so here you kind of see the same thing for Kenya. You see the different dots of the study locations, and what we did is creating a continuous surface map of HIV prevalence for adults and for young adults. So this is what you see here. So on the left-hand side, you see HIV prevalence in these 7 countries for adults, and then in the middle you see HIV prevalence for young adults. The reason we looked at young adults specifically is because we only have prevalence data, and young adults are more likely to have been recently infected with HIV. So it's kind of getting closer to HIV incidence. And what stood out here is that if you look at HIV prevalence in adults, there's a lot of heterogeneity, so a lot of variation in prevalence levels. In some areas lower, in other areas higher. Mainly in the southern parts of these countries, HIV prevalence is high, which is shown in purple. And then if we look at HIV prevalence in young adults, we see that these high-risk areas, so the darker purple red areas, are smaller and more concentrated. And for example, you see that they're concentrated around border crossings, harbors, also for example around Lake Victoria in Kenya, around the copper mining areas in Zambia. And this really represents prevalence. And what we did next is looking at kind of trying to explain these different patterns of variation. And for that, we used geospatial data. So we looked at urban versus rural residents of these locations and proximity to highways and cities. And we also used like NASA geospatial data on vegetation index, which is kind of a proxy for a level of urbanization of places, which is here in green, and the global human footprint, which represents economic activity. And what we found is that these microepidemics, so the high-risk areas, are largely explained by a combination of different factors, including risky sexual behavior and high economic activity. And this is important for us to be able to further optimize healthcare tailored to population's needs and looking into where do we kind of have to provide which services. So next we looked at healthcare delivery. This is a collaboration with people from the AIDS Economics Network, where we looked at different models that can be used to optimize ART, so antiretroviral treatment delivery, and possibly reduce costs. So for the study, we kind of gathered different examples of innovative service delivery models in different African countries. And we created this overview. So in this kind of wheel-shaped graph, you see 12 models that can be like that kind of fall under 5 types of innovations. And I will quickly go through them. So the first one that I will also talk about later is integrating ART. So as I mentioned so far, ART is often delivered through vertical clinics. Integrating ART means either adding other services that people accessing ART need into these existing clinics and existing models, or offering ART in other settings. Then we could modify steps in the ART value chain. Here, for example, we can think of ART provision by community healthcare workers. We can also eliminate steps in the value chain. So think here of immediate start of ART, so when people are diagnosed, immediately starting treatment, or also less frequent pickups, for example, pickups every 6 months, changing to every 3 months, changing to 6 months. So these are the most important ones, and then the one in green is the vertical ART model, which still in some settings might be the most ideal model. In this study, we did a big systematic review. This review was a collaboration for an expert panel by UNAIDS, where we looked at potential benefits of integrating HIV services with other healthcare services. And the could be of potential benefit in reaching these 95 targets that I mentioned. So for this study, we included all studies that were either experimental, so randomized controlled trials, or quasi-experimental, so for example, pre-post studies that looked at integration and had a non-integration comparison. So here on the map, you see all studies that we included. There were 104 studies in total. Many of the studies were from South Africa, Kenya, and Malawi. Overall, most studies were from Eastern and Southern Africa. And they included different types of integration. So many of the studies, so we looked at the 2 directions of integration. So either integrating HIV services into, for example, tuberculosis care, or into other types of care, or the integration of other types of like disease services into HIV care. And most studies conducted were on integration with tuberculosis services and maternal and child health services, as well as sexual and reproductive health services. And we looked at different outcomes, mainly related to utilization of care, as well as health outcomes. And I will go through a couple of them. I think this one is the most important. So here we looked at outcomes with regard to uptake of HIV testing and counseling. And you see here in this forest plot the integration versus non-integration comparator, where you see that for the 37 studies that reported on this, mostly the studies reported on better uptake of services in the integrated setting compared to non-integration comparison. And what was interesting is that there were not so many studies at this time focusing on the integration of HIV and non-communicable disease services. I know that now, like many studies have been ongoing, so I expect that this evidence will increase the next couple of years. I think I will skip through this because it might be a bit too much detail for now. But what I do want to mention is like what we found in these studies in terms of critical enablers and barriers is that whether integration works or not very much depends on the setting. So on the one hand, it really depends on, like for example, if there's sufficient human resources and adequate staff training, and also integration tended to not be effective when the integration happened in HIV clinics that were already overburdened. So why is this important? The broader agenda is kind of to look at whether we can integrate these relatively well-functioning HIV systems with care for diabetes and hypertension. And here you see why. So here on the left-hand side in blue, you see prevalence of HIV and the current cascades outcomes for Sub-Saharan Africa, which are for most countries, relatively high. So the number of people with HIV diagnosed, but also people living with HIV on treatment and control is all fairly high. Whereas if you look at outcomes in cascades of care for diabetes and hypertension, which you see here in orange and purple, outcomes are still very low. So there's this idea that we might be able to utilize the existing HIV clinics to expand care to diabetes and hypertension. Many studies have been ongoing, and I will highlight here a couple of the analyses that I've been doing with my collaborators from Emory, so Felix Teufel and Professor Mo Ali, that are here, as well as Rodrigo. So this is a study that kind of came about when writing a commentary on availability of blood glucose lowering medication for diabetes, where we find that actually there are not many studies out there that present national level availability of diabetes drugs in low and middle income countries. So that's what we looked at here using the HPAC data. And what you see here is that the share of people with diabetes who are diagnosed and treated varies greatly across countries. So in light blue, you see the people with diabetes who are undiagnosed, which you see here that varies a lot by country, but also if you look at the people who are diagnosed and are on treatment, the proportion of people using insulin versus oral medication varies greatly, which again could be an argument for looking into integration of these services. Skip for this. So this is a systematic review I've been involved in that is led by my collaborators and my team from the Health Systems Innovation Lab, where we did a big systematic review looking at the global economic burden of ischemic heart disease, economic evidence from the provider perspective. And we found, so we focused on all countries, so high income countries as well as low and middle income countries. And we find that most evidence on cost that is available is from high income countries and lower middle income countries, or higher middle income countries. So you see here the costs for ischemic heart disease per patient and per episode, where the costs were generally lowest for Brazil and highest for the US. And this is important because cardiovascular disease in many countries and also across low and middle income countries is the #1 cause of death, also in many of the sub-Saharan African countries. So this is this next paper is work in progress with my collaborators from Emory, where we looked at trends in BMI levels among people living with HIV in sub-Saharan Africa versus people without HIV. So here in kind of the top bar, we see the data for men, and in the lower bar, we see the data for women across 10 countries. So for this, we used demographic and health service data again. And overall, what we observed is that BMI levels in people living with HIV have exceeded or are on track to exceed BMI levels for people without HIV, potentially causing a risk for cardiometabolic diseases, and thus being important to further look into. This is still very much work in progress, so yeah, more to be done here. This is another study we did in collaboration with Emory, where we looked at, so here you see for 3 countries using DHS data. So we looked at Lesotho, Namibia, and South Africa. In the first bars, you see the hypertension prevalence for people with HIV, which is here in light blue, and without HIV, which is in dark blue or darker blue. And next to that, you see the hypertension cascade outcome, so awareness, treatment, and control. And we saw that hypertension awareness often is modestly higher among people without HIV. So this is something we kind of further have to look into, whether this is really the case in all countries, or it could be that this is kind of masked by the fact that people with HIV might receive less diagnoses so far. So overall conclusions from this work is that there's a big variation in HIV burden among adults and young adults, which highlights the need for tailored HIV services, both tailored to population needs as well as to location needs. Healthcare utilization and health outcomes tend to be better in integrated settings, but there's no standard model. And utilizing existing HIV systems could be an option for expanding to broader chronic disease care to meet the changing healthcare needs, but there's still much to be done. And over the next year, I'm hoping to further look into this to some extent. So this will be work I'm doing with Health Systems Innovation Lab in collaboration with Emory and others, where we look into kind of 3 objectives. So the first is really further mapping the variation in chronic disease prevalence for HIV, diabetes, and hypertension. Then looking at current healthcare delivery models and how healthcare for chronic disease care is currently kind of there and how we can further innovate it. And the third objective will be talking to local stakeholders and experts to see which innovations we can use where to further optimize care. So these are the references. Thank you everyone for your attention.
There is a question in the chat. It says Ethiopia is one of the countries with the highest disease burden, but still have viral load surveillance is in dire shortage, mainly because programs phasing out and weak integration. Have you tried to look into it?
Yeah, so if I understand it correctly, the question is, will integration be a good model for a setting like Ethiopia? And I think this is a very valid question. This is also a question that many people have raised. Kind of the fear with integration is if we integrate services for HIV with other healthcare services, where we kind of lose the successes of HIV, because cascades of care outcomes in many countries are better than, for example, for diabetes and hypertension, but still we're not there yet. And also we have the declining funding. So this will really require for every country and even at subnational level specifically looking into what will be the best models for this setting. Will it be integration? Will that be a good option? Then with what kind of services do we need to integrate? And maybe integration for this setting is not a good idea and we should kind of stick with vertical care and further optimize this. So this is a valid question, valid concern, and really I think requires a setting specific approach. I hope that answers your question.
Oh, sorry. I was thinking a little bit about what you said earlier, and I think you alluded to the importance of healthcare workers and playing that particular role that they have, especially in these vertical programs. So one thing that's always talked about is that if you add more burden to people, again, integration may fail, HIV care may get worse, there'll be no improvement in the NCD care. Have you guys thought at all about, instead of thinking of it as an integrated model that still retains the same human resources, that you actually think of it as an integrated model where, because it's a catchment, because people come for their HIV care already, that's the opportunity because they come there, and then you actually have to supplement and add human resources, which means investment from countries. But what that investment might look like in terms of what level of human resources you need and what that might cost. Have you guys thought about that?
Yeah, for sure. I think this is a really good question. It's definitely something we thought about. And again, I think this really depends on the setting. So we see in many of the sub-Saharan African countries with high HIV prevalence levels, disease like HIV systems, including the services offered by community healthcare workers, are already like overburdened in some settings, or maybe not overburdened, but people are really busy already offering these services. So then the question is like, should you add more? I do think it's valid to kind of first test, does it make sense to integrate these different services? And then if it works in the case where services are not yet overburdened, then we should, I think, look into how can we add more people to actually provide these services, because logically the demand will increase when we expand these models.
Okay.
Good job, Caroline. In connection to that, if you go back a couple slides, this directly relates to Dr. Ellie's question, to the differences. Yeah, go forward one.
This one?
Yeah. So you see these differences in hypertension awareness is modestly higher among people without HIV. I think it speaks to the idea that you'd imagine that people who have HIV compared to not are interacting more with the healthcare system. Sorry, I missed the start of your talk, maybe you went over this a little bit. But do you have any idea of kind of our hypotheses that explain what it is about not having HIV that might cause people to have more awareness and more treatment for diabetes?
Yeah, I think it can be different things. So this is still, like, I want to stress, this is still very much work in progress. So everything can still change. And for hypertension prevalence, we looked at hypertension measurement as well as self-reported outcomes. So this is important to note. But then I think, like, if you look at where people seek care, it can be that people living with HIV do not tend to seek, like, this is all speculation, we haven't looked into it, but like I can imagine people living with HIV would tend to be less likely to seek care for their other diseases or conditions because they might think symptoms have to do with their HIV diagnosis and seek care for their HIV there and do not like get care for example, hypertension and diabetes. So this is, I think, one thing that potentially could explain it.
Like going off of that, I think if that is your assumption, then it probably would make sense to split up the diagnosed or aware group by whether or not they're treated. So to really have one that's like diagnosed untreated and diagnosed treated, because like if they're diagnosed and treated, then they will have less symptoms. If they're diagnosed and untreated, they might have more symptoms and seek care more. So I think this different operationalization of the cascades might be actually useful there. That is your hypothesis on which you're working.
Yeah, I think that's a great idea. We should definitely look into that. Are there any other questions?
Yeah, this actually relates to a few slides earlier where you showed these concentrations of the prevalence for both young adults and adults in the African context. So regions of high economic activity or ports, etc., you found higher prevalence, which I guess is expected. So how do you read it? I mean, I imagine there are interventions that are therefore focused on the interactions that people have at these very, very high risk areas. On the other hand, NCDs, I guess they are not really clustered. There are no high risk areas. All areas are equally high risk for NCDs. So moving forward, when you're thinking about integrated care, how do you reconcile these areas of high risk and for the HIV and general, non-clustered prevalence for the NCDs? And is there any innovation that can be thought of in terms of how to integrate?
Yeah, I think that's a great question. And what comes to mind is, first of all, what I think is important for HIV, but also for cardiometabolic diseases, is to kind of stratify by urban and rural. I think for all these diseases, service needs might be different in urban settings versus in rural settings for many of the countries we're looking into. And then when it comes to HIV services and when and where to possibly combine with NCD service, I think we kind of, how we see it so far is splitting by more HIV prevention efforts. So for example, for younger and more at-risk populations, so far the focus is more on HIV prevention and early diagnosis. And then on the other side, there is the ART and chronic disease care. And I think mostly for this last group, there's a lot of potential for looking into ways to expand services to like broader chronic disease care services.
And the ART is actually also chronic management.
Yeah, exactly.
Just like other chronic diseases.
People living with HIV require ART for their lifetime. This is chronic disease care.
Yeah, and a really interesting point that you're raising there, because I've just been you started with this assumption that like you have this kind of clustering in certain areas for HIV, and that you wouldn't expect that for non-communicable diseases, and that made me think whether I would actually agree to that.
Yeah.
Because it might also be that like entities also cluster very much in certain urban areas with high economic activity.
That's true.
Yeah,
And I guess when like we want to like assess like or think about integration, I think it's one of your aims in your grant proposal as well. It would be really important to like map really where are these people, and only if they're in the same areas then it makes sense to integrate. Do you know anything like that has been done or
Yeah.
is feasible?
exactly. So this is something we've looked into, and I fully agree with you. And this is initially always the assumption that like when we look at infectious diseases, it's kind of logical that we would find clustering due to disease transmission. But then if we look at non-communicable diseases, the question is this the same kind of relatedness in populations, is it there? And in fact, many people have been studying this. Also, my previous research group at Erasmus did like microsimulation mathematical modeling to look into, kind of, can we use the same transmission models in a way for non-communicable diseases? And in fact, for example, looking at obesity, but also diabetes and hypertension, to a large extent, this is the case due to the underlying like social interactions, but also to the relatedness, for example, in nutrition and exercise. So this is a really good point that you're raising.
Now when I think about it, it would make sense because all the risk factors are generally clustered within households and communities, so it would make sense that the prevalence would also be quite clustered. And then if you can map on HIV, which is like an infection, not an infection disease, but a viral borne versus an NCD, which is lifestyle. Yes, it can come up with very cool, ideas even on how to manage.
Yeah, great point.
So we have someone with a few questions. They can unmute themselves to ask.
Can I ask a question?
Yes.
Yeah.
Okay, thank you. I'm Ayo Guntade. So I'm joining here from the UK. So you presented very interesting results, and I'm more concerned about the integration of HIV care into current cardiovascular care in the continent. I mean, in sub-Saharan Africa. But given the paucity of cardiovascular physicians and endocrinologists who are still struggling, with treating patients without HIV, what will be the opportunity cost, of taking these people away from current cardiovascular clinics into HIV clinics, especially since most HIV clinics are still run within maternal and child health care services, rather than in mainstream internal medicine clinics in the continent. What are your thoughts on this?
Yeah, thank you for raising that question. So I think before looking into opportunity costs, what we first have to do is kind of maybe take a step back and see the people in need, like the people currently enrolled in HIV care and potentially in need of other care. What would be the best locations for them to seek care, and how can we, based on that, kind of best optimize these models? So in my opinion, like I don't really see it as taking people away from one clinic and enrolling them in the other, but rather looking at where do people currently seek care and how can we combine these different levels of care so that people don't have to go to different locations. And it could be indeed in some situations that, like in some situations it might be sufficient to integrate, in other situations it might be better to kind of keep systems the way they are now so that people seek for HIV care separately. So I think like before looking into opportunity costs, it's worth first looking into what would be the possibilities for further adapting these models.
Thank you very much. And just as a follow-up, will you think that having HIV care services care more efficient than the way it is being run currently in many countries where it is majorly within the maternal and child health care services? Can
you repeat that question?
So I was wondering if if HIV care services are domiciled under primary health care clinics, whether they will be more efficient rather than the current practice in many countries where they are being run, in maternal and child health care facilities.
Yeah, so that's I think again related to what is the best point of care for the people we want to reach with these services. And if it's really purely for HIV, then maternal and child health care might still be the good place. If we, for example, also want to reach people without HIV that are seeking care for cardiometabolic diseases, then we might have to shift away, and it might make sense to look at primary care as a kind of initial point of care. So it's hard to kind of answer this question for a general setting. I think it will really depend on how services are currently delivered and what the best point of care should be for the population we want to reach.
Thank you.
Is there another question? Is this another question in the chat? Claudia?
I think that's it.
Yeah. Are there any questions? Yeah, go ahead.
Could you maybe go back a couple of slides to kind of like the implications of your systematic review on integration? Because there you talked about like I think there was enablers and barriers. And I've been wondering, like, how did you arrive at these conclusions? Is that what you found the people in those single studies writing about? Is that from the existing data? Have there been some like sub-analyses in your meta-regression? Could you speak a bit more to how you arrived at these conclusions?
Yeah, I can. So these conclusions were derived from what the studies that we included talked about directly. And I think what is good to mention here, so this is what these studies talked about directly, but then there was also the big component of when we look at, so what I state here is that one of the barriers includes imperfect fidelity of the integration intervention. And here we saw that some of the studies that reported on integration and found that the results were less positive than they kind of would expected. They found that kind of the implementation of their intervention was imperfect, and they listed that, but then there was also a large proportion that didn't look at integration fidelity at all. So one of our conclusions here was that like when we look at these different integration interventions, it's important for these studies to, next to the outcomes they want to look at, also look at fidelity of their implementation of their intervention as a whole, and report on this in their discussion. Does that answer your question?
Yes, thank you.